Well, shukran jazilan for the invitation to attend the second conference in Nazareth of the Israeli Dental Association. This is my 5th trip to Israel, and I have high respect for Hadassah and Tel Aviv University faculty and friends from Hadassah. And when Jonathan Mann sent me an invitation to come, I think I answered him almost by the second. I said, of course, I will come and be here with you. But now I learned a lot about the Israeli Arab Dental Association, and if there is any opportunity to help you, I'm more than happy to help you. I do many things. One of them is the Bridge to Peace program between Hadassah, Al-Quds, and also Temple University, and hopefully we'll add students from Tel Aviv, and also the Alliance for Oral Health Across Borders, which is about now 40 dental schools from all over the world. My lecture is, I'm a man of action. I do not like to talk only for the sake of talking. So my lecture sometimes may appear simple or simplistic, but it conveys to you messages as you design the public health program, especially as you're starting with the public payment system for care for children. I have had experience, significant one, in Canada, as well as my current position in financing of dental care, and have studied systems, so maybe that will help you. So the first thing, I'm going to have to give 2 lectures. One is to define why we are focused on comprehensive dental care versus the episodic care. When we have students coming from overseas at Temple, the first problem I see is that they're focusing only on what they need to treat or what they think they want to treat, without looking at the patient as a whole. The practice of dentistry is successful when we look at the patient as a whole, not just the mouth, not just the teeth. So what is this concept and how to define it? First, where did I come from? I came from Pennsilvania, a state that has about 9 million people in it. The state where the Constitution was signed, the U.S. Constitution, and the first capital of the U.S. before Washington, D.C. was Philadelphia. The brand of Temple University was established in 1863, so we have almost 154 years of existence. We have experienced all, and I actually have a very large museum collection, experienced all the phases of dentistry. What does that mean? And I want to start with some definitions. When I talk about healthcare as one word, because this is a U.S. thing that may confuse people, when I have healthcare as 2 words, it's really sets of actions that any one of us will take to maintain and improve health of a patient. So it's behavioral things that we do, the care we provide. But when we talk about healthcare as one word, so healthcare 2 words is what we do as dentists, what do we do as public officials, what do we do as individuals to promote our health. But when I talk about healthcare, I'm talking about a system, organizations, how we deliver care, the delivery model of care. So these are 2 things that I want to emphasize. So when transforming our health care since 1863, what does that mean? We have adopted, I've been dean for 8 years and 7 months. As I said, as a dean of a 153-year-old school is really a challenge because we have a lot of legacies. But the faculty decided that we will be involved in promoting health. So a dental school is talking about promoting health, not just oral health, not just dental health, but health in general. And I heard Dr. Fakhri talking about that. I'll pronounce you the Arabic word. Talking about that is that the mouth is part of the body, and it's important to think of health overall. And we have a major role to play. And the reason why is that a lot of patients see you, and if you do recall programs and they come for prevention, you see a lot more patients who are coming for health, prevention, recall, than what physicians see. So we aim to be, and this is very important words, and I just highlighted a few words. Our vision is really to shape the future of dental education and prepare dentists and specialists who are leaders in providing ethical care, scientifically based and quality. The reason why ethical is important is that if we lose the ethics part of our profession, we lose our profession. So doing the right thing at the right time based upon the right standards is what we are aiming for. Now, as I said, I'm a man of action. So I really opened a medical clinic in the dental school that's funded and operated by another agency. But now there is a nurse practitioner. This is the governor of Pennsylvania who opened the clinic last June, almost a year ago. And we have a nurse practitioner, 3 units, and we do point-of-care testing. So that means that my dental students and faculty, we could test on the spot for diabetes, cholesterol levels, HPV, human papillomavirus, HIV, do blood pressure, do AKG, and we coordinate the care of patients, our patients. Sorry about that. So we are implementing a curriculum that's focused on really patient-centric. What do patients need? So I see a lot of schools. I travel a lot, see a lot of schools. And I see a lot of schools that are divided into operative, treatment planning clinic, perio clinic, fixed removable, surgery, ortho, and the patient keep move from one clinic to another. This is not patient-centric. A patient-centric will be the patient sitting in the chair and all the specialists will come to that chair. You save a lot of time for the patient and the care will be better because there's discussion among the different specialists. So we're implementing this comprehensive care. We still have very heavily requirement-based system. That means they have to finish 15 crowns and extract 50 teeth and all that stuff, which is important. But on that, we are adding the comprehensive care requirements and completion of cases. And most importantly, which I'll explain what's comprehensive care, according to my definition, is evaluating outcomes of care. We have to show that we're achieving health for the patient rather than just filling teeth and providing crowns and implants. We are working, as I said, in addition to the medical clinic, we have now a movement to develop a diabetes management program. And that's very important because I don't know about Israel, but in the United States, especially in my community in North Philadelphia, diabetes is one of the most prevalent chronic diseases. So it requires a team of physicians, nurses, occupational therapists, dietitians, podiatrists, all working together to take care of the patient in an integrated way. So we're building that system both electronically as well as physically, how we can provide care in one spot for patients with diabetes. Areas of interest is the microbiome research and impact on overall health. I'm going to talk about this in a few moments. We work with communities. We are the largest dental clinic in the United States providing care for Holocaust survivors for free. We have over 100 Holocaust survivors in the United States, in our clinic alone. So we're proud to provide care for communities, children, and elderly. And I think, Dr. Fakhri, you mentioned that the elderly is one of the the largest growth in the United States and many developed countries is in the population 65 plus. So if we as dentists don't prepare ourselves to work with complex populations, complex medical problems, complex dental problems, to work with them, we're going to lose another population that, just like children, we didn't really pay, especially young children, we don't pay much attention initially on. We are calibrating dentists over time. So we're going to have, by August, an app. It's now online where we can share images. We can discuss scores. Is this a good restoration or a bad restoration or a middle restoration? And the faculty will see this all the time, as well as the students. And we're also involved in global education, and I offer the Israeli Arab Dental Association any help in terms of CE. We can send faculty to you here. And then we're doing more things in terms of the CAD/CAM. We're moving heavily into the digital dentistry. Just a few examples of my school. This is the entrance to the school. We have lecture halls that take about 150 students. This is our orthodontic clinic. This is our units, which we renovated. We finished renovation in 2014. This is our preclinical lab, which takes about 150 students. And this is our tree of peace. There's a tree of peace in front of Hadassah, in front of Al-Quds University, and in front of Temple and other 6 schools and locations. So now I'm going to go to the meat of my topic. Dentistry primary mission is really promotion of health. Every one of you is involved in some aspect of promotion of health when you work with patients. But as I said, the success of dental practice is how much you pay attention to your patients and their behaviors to promote their health. So we focus in dentistry when we are educated all into process, doing things, surgical, restorative. The process is important, but it's not the goal. And comprehensive management of dental and oral diseases is the process to achieve outcomes, which I'll explain in one moment. Another point, if you want to leave from here with a message, it says dental care is part of public health. And public health includes dental care. There's a tendency in some aspects, some corners of the public health community to say what dentists do is not important to us. What dentists do is extremely important to public health, because what dentists do, especially when you have a universal coverage for children, these resources are public health resources. But that system has to be part of a promotion of health in children, not just a treatment. Treatment by itself is sufficient but not necessary for health. So I want just to talk a little bit about public health and dental care. As a public health dentist, just to give you I'm sure you're all aware of this, that we went into different eras in public health. Of course, we were dealing for almost all of the centuries of life on Earth with infectious diseases that we couldn't treat until later parts of the 19th century. So the communicable disease era began in ancient time until we were able to use antibiotics and other means, and hygiene, which is very important. It's not the medication that solves the problem. It's actually the sewer management system that solves the major problem. So now we made a significant change in terms of managing infectious disease. We have other problems. Then we moved into the 20th century. A lot of people start to have heart diseases and diabetes. So we moved to the chronic disease era, and we focus on management of these conditions. Again, significant expense without really looking. I mean, we started to look later on in the process into why we have diabetes. I mean, we still haven't answered that. But how do we reduce cardiovascular diseases? All of these are both the treatment as well as the prevention, and the community preventions are there. More evident now when we have successes to report. Then we moved into the 80s, 90s, into an era in public health, which is the health promotion, wellness, exercise, diet. This area is successful also in changing a lot of disease levels around the world, but not in all populations and not in all countries. As I travel, I see a lot of people smoke. Some people smoke in public places. In other countries, that's forbidden. You have to go 20 yards away from the building in order to smoke. Something happened here. Wow. I need something to... Okay, let's escape. Good then. Then I think we are moving now into the system or the area or the era that has not been discussed so far, which is really to move into systems of care, systems to achieve health outcomes, both the medical, dental integration, social health integration, and also we have, as health providers, need to address poverty. Poverty is everything, the root cause of a lot of the problems in the world. And we have to take action in reducing poverty and talking about it, both politically as well as in our programs. So the personal community environments conducive to health, how we change communities to be healthy without asking every individual member in the community to adopt healthy behaviors. So I worked in areas in Detroit where there are no sidewalks. So how do you advise people to walk when there are no sidewalks? And also gun violence is very prevalent, so you may go take a walk and get shot, and that's not a good idea. The other one that's emerging, which I'll explain a little bit, is the microbiome era. So let me just spend some time on this. We are not one human being. God created us. It's a miracle. Each one of us is a miracle. We are one genome, yes, but we carry with us multiple genomes of bacteria. So that's why we are super organisms. There are 100 trillion bacterial cells colonizing the body. Without them, we cannot function. We cannot eat food. There are 10 bacterial cells for every human cell. There are 100 bacterial genes for every one human gene. So we are a lot more complex than we thought about. So why this is important? Because now we can sequence the whole genome of bacteria. And instead of, remember when we were in dental schools, we used to plate one bacterial species and it goes by itself. That is never needed anymore. We can look at a whole thousands of bacterial species at the same time. That means we can now map things differently, understand things differently. So comprehensive assessment of microbiome. Microbiome is natural. Dental plaque is really not, it's a slang word, it's like a layman's term. Biofilm is external that attach to a hard surface. Microbiome is part of nature. So there are differences in the as more research is happening, there are differences in the between individuals. My microbiome may be slightly different than yours. Within the individual, different sites, the oral cavity, the guts, and then the inter-individuals and also inter-populations. So one of the things that happens in disease is that we have a balanced microbiome. Normal biosis is referred to, and then sometimes our environment, our behaviors, or other factors lead to a switch in the microbiome with the emergence of pathogenic bacteria. Pathogenic bacteria, all of them, most of them in the oral cavity are endogenous. They're not infected from outside. Mutants are there in the oral cavity, except they increase in number when you eat a lot of sugar. You change the environment. So we're changing it from normal biosis to dysbiosis. That's very important to understand and communicate to patients. So now we create disease. Now, I don't know whether, yeah, you can see it better than me. A little bit not well adjusted. But this is saying, I'm going to explain it to you. In dental caries, in different stages of caries, from sound to cavitated, the diversity of the microbiome is different in the lesion. The diversity is significantly different. And the more diverse, the more healthier the tooth surface. In other words, there are so many different types of bacteria instead of fewer types of bacteria. And this one, hopefully, this doesn't show well as well. I'm sorry about that. It shows very well in my screen, but when enlarged, it doesn't. This is called a heat map. And this heat map is really depicting all the bacterial species identified in children with caries-free, who are on the bottom. Here are the blue ones in this area. And then there's a group of red patients who are not caries-free, have early childhood caries. And you can see the diversity and the distribution of the bacterial species is totally different. This is oral microbiome for periodontitis. And again, you see diversity between those who have periodontitis and those who do not. Now we understand that it's not one bacterial species, it's a cocktail of bacterial species. And these bacteria are, and I'm not going to read them for you because the screen is not that great. These bacteria are associated with health, periodontal health, and these cocktail of bacteria are associated with periodontitis. Similarly with oral cancer. Imagine with oral cancer, now there is studies that are appearing that show a relationship between oral cancer and the microbiome. The growth of bacteria on the oral cancer. We don't know whether it was before oral cancer or after. Maybe the tissues have changed, so it attracted different bacterial species. I'll move from here. Then we have this concept. So how do we switch it? Microbial species that have potential to remodel a microbial community in ways that promote disease pathogenesis. There are some species that could shift it, and they're called, even when they are low appendance. So just like very bad criminals in a society, few of them could change the whole society. Not that everyone is bad. And these are, for example, P. gingivalis is one of these species. Candida albicans in dental caries, it changes the environment, and mutans with Candida albicans changes significantly the disease level. So why I'm saying that is because now I'm thinking, and I'm early in the stages of this thinking, that the microbiome in our cavities where everything happens, and all the factors we talk about, including dental care, affect the microbiome, because the service of restorative materials do lead to different growth of microbiome on the surface of a restoration. So it's very important. This is a study that we're doing at Temple where Candida albicans with mutans actually results in more severe caries. So now we are now looking at these communities of bacteria and how could infect disease. Now, it's very important from a public health. I'm presenting you a biological part of public health. But what affects this? Now we come to the behavior. It turns out that breastfeeding is a highly protective behavior in terms of creating a healthy microbiome. The milk, the mother's milk, have proteins that will grow, create for both energy as well energy for certain bacterial species that are protective. So that's very important. Breastfeeding is important. Delivery methods. Now they're using bacteria that are taken from the vagina to infect a child, because a child who's born in cesarean is more at risk than a child who's born natural birth. This area is emerging as a parenting, the sharing of food, the level of disease of the mother may affect the child. Now we have biological reasons more and more to understand that. The foods and drinks affect sugar. Affects a lot the carcinogenic bacteria. The medications that are used, that's why the elderly population is very important to understand that the more drugs that they use that reduces the saliva flow, it creates a problem for elderly in terms of dental caries and root caries. Now we know that there are other bacterial and fungal species that could impact on the microbiome. Now we are into a transformative era into dental caries and dental care and healthcare. There will be a significant change as more science is coming. I thought that, at this age I have seen it all, but this is now a whole new book chapter. Whole book is being written on this area of management of disease. So my definition of public health is not what the American Association of Public Health Dentistry writes on its website, and it's more complex. Dental public health is a scientifically based specialty of dentistry and public health. So we are both a specialty of dentistry and we are a specialty of public health. We integrate the knowledge and experiences from dental, behavioral, public health, and biological, educational, political sciences. Now it's more complex. We understand how policy, the minister here is talking about policies that impact on health. With experiences from business, management, marketing, and advocacy to promote health. We need to understand how group practices work, how individual practices work, how to position them to be in a better position to serve the public and promote health. And provide both primary, secondary, and tertiary dental care for individuals and populations. I do consider what I do at the dental school to be part of public health. Because if we train a bad dentist, that dentist will have a significant impact on the health of the patient and the population they serve. One of the things, again, the projector is not showing these slides, so I'm going to explain them to you. The point I'm raising is we cannot rely on one system and one solution to address disease issues. Dental care by itself is not sufficient. This is example from New Zealand. New Zealand, since before World War I, had a program, a school-based program, where every child is covered. They invented the concept of the dental therapist working in schools. And you can see that still there's a difference in untreated decays between different socioeconomic status in New Zealand. It should be balanced. Now, this is my study in Nova Scotia, where I lived for 9 years, Nova Scotia, Canada, where that has a universal dental care program. And you can see that even when then everyone has the same access, the same amount of payments, there is differences between highly educated children of highly educated families versus lower educated families. So it's not just the dental care that solves the problem. We are in the medical field. They talk about this concept of moving from value to volume, from volume to value. We want to look at what we provide. Is it providing really health for the patients? It's not how many we provide, because the healthcare system in the United States cost us about now 18% of gross domestic product. We are the most expensive country in terms of of healthcare. But we don't have the best outcomes. We rank low in a number, I mean, compared to other industrialized countries, low in a number of factors. We are highly tech, and we're very process-driven. We are fee-for-service organizations. A hospital room in the United States, if you pay out of pocket, is like $3,000, more expensive than the Waldorf Astoria in Jerusalem or the Ritz-Carlton or any other of the 5 or superstar hotels. Unless if you go to Dubai and you go to the Burj, whatever, it's $10,000 a day. So now we are looking at value to patients and communities, which I think what the minister talked about as well. Deliver services to the suburbs and the rural areas. So there are certain principles with Michael Porter, who started this field, that I would like to share with you. One is define the outcome first and then design the inputs, processes, and outputs. If we want disease-free mouth, then that's the outcome. Then we have to design a system to do that. We don't pay only for procedures to deliver care. We have to pay the dentist extra to keep the mouth healthy from disease. It's a totally different concept. So what's the outcome that you value for yourself and for the community? So the question is, in a comprehensive healthcare system, achieving outcomes, what outcomes do patients want? The population wants? What providers can do to achieve these outcomes? And what are the inputs and processes of care? In dentistry and in dental education, we focus so much on the third rather than the first. And that needs to change. Since the value depends on results, not inputs, value in healthcare is measured by then outcomes achieved, not volume of services. I have said that. It's very important to consider that. Value is measured by the process, achieved by the process of care, so we have to define the process to achieve that. Unfortunately, value-driven outcomes of dental care are not widely used nor agreed upon in dental or healthcare. This is not something we heard in our dental schools, not something we're hearing now into payment systems. So that's why I'm here. I came all the way. This is, by the way, today I'm going to take my 4th trip across the Atlantic in 1 week. And I enjoy every minute being here. This is something that you could take a leadership in starting the discussion. I saw this morning very interesting and very forward-looking ideas. I heard very forward-looking ideas to achieve that. This slide, which again is not being shown very well, is very interesting. This is a very recently published study on what happens to children when we provide them care under sedation, deep sedation, general anesthesia. A growth market in the United States for pediatric dentistry is to open, and we have less rules than you, by the way, so it's to open a fully accredited sedation center, which will have the specialist dental anesthesiologist, dentist anesthesiologist to be correct, and they will provide care with pediatric dentists. We have companies that are opening these clinics all over. Hospitals have long waiting lists for children, because if a child says cries, and you know children do cry, 1 or 2 year old, take them to the hospital. Do you know why? Because that's a lot of payment, $2,000, $3,000 just for sedation, in addition to the dental fees. So we have a growth industry in that. And what happens is that 1 in 5 of the children will come back within about a year to 18 months. Come back to the OR again. The reason why is because we didn't stop the reason why those children have early childhood caries. And the mother behaviors stayed the same. So we really didn't do any treatment. That's exactly the example we don't want to have. And we as a health profession and leaders, we need to talk about it. So this is what it shows. Interesting. These are, so let me read it here. Effect of dental general anesthesia, mother's educational level, dental anxiety, and childhood caries on the number of filled and extracted permanent teeth at age 17. So they looked at the children treated early and happened to them age 17. And this is positive, this is negative side of the equation. But here where it is, it says if they have general anesthesia before, they're more likely to have a lot of caries later on at the age of 17. So we're not solving the problem. Okay? So what are the outcomes that we value, or at least I value, because it's my presentation, but I think that the dental profession will value. I'll skip this slide. What we value is number of sound tooth services. We spend all our time measuring tooth decay. We should actually look at what's the number of sound tooth services in the patient, how I can keep them sound. So that's the most important outcome. Then the second one is the concept of what are the initial lesions that are not cavitated, that I don't need to drill, but I could prevent them from progressing using whatever existing technology we have, sealants, fluoride, silver diamond fluoride, new technologies that are emerging. That is an outcome, because if I keep them from going to a full-fledged cavity prep and restoration, I save the life of the tooth forever, for a long period of time. And then if the patient has cavities or dentinal lesions that requires to be treated, then that should be treated. They should be treated. That's another outcome. So it's called those tier 1 outcomes. Unfortunately, as you all know, we are paid, and hopefully in Israel will start a different thinking over time in the next few months or year, is to look at how to reward for better outcomes. All of the payments is on the third one, which is filling teeth. So that's not the solution. And that's we run into this huge spending, but not achieving the outcome. Then the issues of number of dental visits, the process of care, do they come for recall? Diagnostic errors that we make. If you move from one dentist to another, more restorations are going to be provided. Discomfort, pain, anxiety, but these are most important. Sustainability of health. As the patient know, the mother or the patient and adults know how to keep themselves or the child health free from disease in the future. Do they follow the right practices in oral hygiene? And also dietary. So were we able to change their behavior to positive? No one is paying dentists today for these outcomes, zero. But they are very important because this is what will impact the disease in the future. And then also coordinated preventive care. Do they come for preventive care? What do they do at home? Do they come preventive care in the office in a scheduled based upon risk, their risk status? So now this is another point for policy. I don't think graduating dentists alone will solve the problem that I'm talking about. We need a team. And the team exists in the United States currently. We have 50 laws, not one. We have 50 laws of practice. There are similarities, but there are differences. You can be licensed in New Jersey, but you cannot be licensed in Philadelphia based upon certain credentials. And we are separated by a river. So across the river, you're licensed. Across the river, you're not licensed. It's crazy. But we have dental, of course, we have dental hygienists, dental assistants, but we also have something called expanded function dental assistant. The expanded function dental assistant could restore teeth after the dentist gave the anesthesia and drilled the tooth. And she or he will come and just restore the tooth while the patient is seeing, the dentist is seeing a second patient in another chair. What happens is that they could increase volume, but they achieve the same result. The reason why is that Medicaid, our similar public system, doesn't pay full cost to dentists. It's anywhere now in the range of about 40 to 50% of the fees that the dentists charge. So we need a team to achieve that, and these are the different types of team members. We have also in Pennsylvania advanced dental hygienists who can go on their own and do screenings. They could do cleanings. They could place sealants and place fluoride. And then they take radiographs and send them to the supervising dentist somewhere else. Not perfect, but this system exists. Dental therapists are really a new concept in the United States. It has been practiced around the world. There's a role to play for them, but not as independent providers. They have to be part of a system that is led by a dentist, where there's a dentist clinic to provide full care. And of course, you have dentists and specialists and nurse practitioners in the future. So my vision for dental care in the future is that we'll be focused on defining and measuring and achieving value for patients and for the payers. We have a lot of insurance companies now are moving to pay per performance. Payment for outcomes is happening in the medical field and is going to start in the dental field. Measures and shares information on outcomes, so we know that we're doing good for our patients. That has to be public. There will be more multidisciplinary group practices, at least in the United States. We are moving heavily into, there will be maybe 25 to 30% of the dental market will be group practices. Good or bad, we have to build them to be good and control them to be good. There will be more medical care or nurse practitioners in dental practices. We're focused more on a population health rather than just the, so if you approach the schools and the churches and synagogues and mosques around the practice and include them into the screening and education and coordination of care. Sorry about that. And biologically based interventions to create healthy environment. So comprehensive care has 4 components to it. That's the definition. In order to achieve what I talked to you about, the outcomes, I need to stage the disease. And you're all familiar with gingivitis, periodontitis, different types of gingivitis and different types of periodontitis. The perio field has really advanced, more advanced in staging disease and managed based upon the stage. In caries, many parts of the world, they still have the stick, no stick philosophy. Now, in 2002, we formed a group called the International Caries Classification, ICDAS, International Caries Detection and Assessment System, which actually defined criteria. But given it is a committee, and a committee of people from different parts of the world, it became too big and too complex. In my opinion, the system is good for research, but it's not good for practice. So we developed in 2013 a system called International Caries Diagnosis and Management System. I wrote them, but I forgot the acronym. ICCMS. So ICCMS is really a full management system. The first thing you talk about is stage the disease. So I talked to you about sound. We have lesions that we don't need to drill, but we can intervene to stop from progressing, and we have lesions that we need to drill. So at least these 3 categories have to be in the system. Some people want to add more, that's fine. We need to assess why the patient has disease, because the risk assessment is very important. Once we know that, then we can design a tailored preventive program for each child. Not every child has to come every 6 months. Some child may come once a year, some child every 3 months. We have a patient in the dental school is coming every 2 weeks. Otherwise, the family doesn't want to take them to the OR, to the operating room. So we're working with them in order to control the disease. Then we have a comprehensive plan. Any comprehensive plan should have the following components. A prevention component. How do I keep sound tooth services healthy from disease? And also, how do I keep restored tooth services healthy from disease? So a prevention component that is risk adjusted. The second part is what I call medical care. Some people call control. Some people call secondary prevention. It's all the same thing. It's stopping disease at initial stages to progress. Stopping disease in the initial stages from progression. So we need to intervene clinically and also at home in order to achieve that goal. The third part will be surgical restorative part, which could end from endo extractions all the way to simple restorative work that we do. And this is where the bread and butter of dentistry is. This is where we spend all our training. The fourth part is really what do I review and when do I review and recall the patient. Because it's very important that has to be adjusted to the patient. Then I look at the fourth part, which is outcomes. And the outcomes have to be discussed with the patients, and the patient agrees to those outcomes. What do they want? Some people want aesthetics, but we need I mean, if you tell, I'm going to work with you so that you don't have more disease, I think very few people say, no, I want more disease. Although we had once a patient who we discovered she comes to help the students. She comes to help the students with treatment. So it's an interesting story. She got a lot more care than she needed. So the steps that I could identify more details is really understand patient needs and preferences. This is step one. That's a discussion, communication with the patient. Clinical staging of the disease, risk assessment, classification. Then we need to train more dentists in synthesis, our dental students, synthesis and decision making. One of the weaknesses is that we need to move from being mechanical in our approach to more analytical in our approach to develop treatment plans. Then we have communication with patients and they understand. Behavioral change plans that should be developed for each patient and a risk reduction plan and may include medical conditions that they have and what advice we give them and how we navigate and coordinate their care, and then the provision of non-surgical and surgical care. So this is really the plan. Now, to take this to public health arena, because that's what I described to you is public health, but now I'm going to talk about populations. What public health dentists do is really assess the population disease levels, clinical, social, behavioral, and other risk factors. So we measure disease, look at why, beliefs, practices, and so on. So that's really step number one. First, you have to understand and define the problem. We analyze the data. We come with a diagnosis for the community and what do we target that is modifiable. And then we develop public health plans and we implement them, whether it's school-based, nursing home, whatever it's. And then we evaluate the outcomes. So this is really the same steps in clinical care and the same steps in public health. In public health, however, we should have more outcomes because not just the absence of disease. In other words, if we take DMFT, the DMFT is declining, or periodontal disease is controlled, or oral cancer is not, prevalence declines, morbidity, mortality declines. These are outcomes of absence of disease. Social health, individual, family, and community social environments, is it improving? Behavioral health, both of the individual as well as community. And then the economic health, reduce direct and indirect costs to society. Is the investment that you're making now into the public health program and the coverage for dental care is going to improve the health of society? And what's the cost of that? Because somebody is taking money from one side to pay another program. There's no free money. So trying to put all this into dental caries, the way we view dental caries today is really a microbiome or microbiological shift within a complex microbiome. So we have a microbiome on the oral cavity, 10 trillion cells, maybe about close to 3,000 types of bacterial species and types, and affected by saliva composition, exposure to fluoride, dietary factors, and oral hygiene practices. So dental caries is really the imbalance among these factors. And our job is to balance the system. So this is one definition of caries, and I think I shared these things with you. We no longer, when I was in dental school, they were talking about 2 species causing dental caries. And now we have, whatever, they are about 10 species that we know. And now we have interactions among species as well. Candida with mutants, which we never really understood before until recent research is started to be published. So it's more complex than that. But the behaviors change the microbiome. The behaviors causes dental caries. And that's very important. But the way it's changing it is through changing the intraoral cavity microbiome and microbiological ecology. Dental caries can be reversed or stopped. And you see that in elderly individuals who have not received care. You see a lot of arrested lesions that are hard. And you cannot, even if you push the hardest with a sharp explorers, you cannot go into these dark areas. And sometimes it's better to leave them and not try to fill them because they existed there for decades. But this concept of arrest has been with us for a long period of time. So just to unfortunately, everything I'm saying to you, we are implementing at Temple. So it's not like I don't want to be preaching to you, but not doing. And we're moving away from the system that we have been working under. We have inconsistent understanding of dental caries and etiology. I'm not saying that 100% of the faculty believe in what I'm talking about. Is about 85% of the faculty, because I surveyed them. We have one faculty who will fill everything. And I don't know who he is or she is, because it's anonymous. Diagnosis, we have inconsistency among our faculty and also inconsistency among dentists in deciding what is caries and what's not caries. And that's documented. We don't focus on sound initial lesions. Everyone's focusing on lesions to be treated. When we look at the community and clinical systems are focused on restorative care and not full care. And preventive care is routinely applied. This idea, this is a secret that we know very well who look at systems in health services, is that majority, when we tell students to buy a practice, tell them how many hygienists they have in practice, what's the recall rate, and then we ask them the third question, how many new patients they come to them every week or every month. The reason why is that the recall rate is high. That means you have a healthy population that comes to that clinic, which is provided with preventive care that's provided by a hygienist, which is paid significantly lower than the dentist. And that's a sign of a health of a practice from a practice management point of view. So that's why one chair practice in the United States would never make it. You require, I mean, they could make it if they charge a lot of money, but require this recall program to be implemented. But there's a lot of routine services provided in that box. It has to be adjusted to risk. And some dentists and many dentists do that. So our goal in comprehensive care, as far as the ICCMS system that I told you about, is to preserve dental tissues first and restores when indicated. Very important question. Our task is to preserve what God has created and restore only when indicated. So I was in Turkey about on March 16, 17 at a Nova Center, which is a home or a center for children with special needs. In order to train 15 Turkish dentists to do screening at that home where they're starting a program, we really examined the adults because it's very difficult to train and have 5 dentists examining a child with special needs. And it's interesting, these adults don't have a lot of care, so you see what happens to these lesions. These are all arrested lesions. Even the cavity is arrested. And I put that test to the students in terms of what to do with this restoration. It could be doing nothing, could be restoring a small cavity, sealing the fissures, depends on the age. It could be, for a traditionalist, will be to do a GV black cavity preparation to remove all these black darkened fissures which are arrested. Similarly, this is another arrested lesion. Now, I don't have radiographs, but it could be also treated conservative. But it may be opened. It's better or maybe not. It's just to seal it. This is the third one. So I saw a lot of these work in Turkey. So this is the end of my first presentation to you. What I'm saying is not new. It has been talked about for over 100 years. And GV Black is actually the most visionary leader in dentistry ever. And we've not gone to a dental school, by the way. The day is surely coming when we will be engaged in preventive rather than reparative dentistry. So he predicted that over 100 years. When we will so understand the etiology and pathology of dental caries that we'll be able to combat its destructive effect by systemic medication. Thank you very much.
I want to thank Professor Ismail Ameed for the lovely and nice lecture. We have a certificate for honor.
I have another lecture. Thank you very much. Thank you very much. So this lecture should have been given tomorrow, but I decided that for practical, our graduation is on Friday, starts at 2 o'clock. And the only way I can do it is to fly overnight to make it. So I apologize for that. So a continuation on when I started the end of my last lecture, I was talking about dental caries and definition of dental caries. Now I'm going to describe to you maybe oversimplistic but very structured program for how to manage the disease based upon the current understanding and evidence on caries. And this guide actually is available in print. I could share it with you, is what we are using to train faculty and students. So I'm going to start first by foundation knowledge about caries. Caries is really a result of demineralization, remineralization that happens, or the imbalance between demineralization and remineralization that happens almost every time we eat. And today after lunch and after eating, all of us, I ate desserts. So there has been a drop in the pH. There has been some demineralization. And my saliva, hopefully, will protect me through a process of remineralization. When the balance between the demon and remin happens, then there will be a loss of tooth structure. So what we have is that the demineralization of enamel is not contained or reversed immediately with remineralization. Then loss, if it is not contained or reversed, then there will be a loss of hydroxyapatite crystals, leading to microporosity. The first stages of the microporosities are, we cannot see them with the naked eye. Hopefully one day we can detect, but it would go crazy to detect demineralization that is moving to the size of demineralization at the micro level. So the outer 100 to 200 microns of enamel is where the caries usually starts and cannot be detected at that level at all, unless the lesion will progress. And when the lesion progresses, what happens, there will be a change in the refractive index. And I don't know whether you can see this photograph here, but there is a demineralization at the neck of the tooth behind the gingival line, and that tooth, the canine. So that's the first sign that caries is happening. Now, traditionally in dentistry, we have not paid attention to these lesions. But I will try to convince you today that we should, and for many reasons. So when the demineralization happens over time, then there's this difference between what? When the surface is wet, the refractive index is similar to that of enamel. When it's dry, it changes. You know, if you have a sponge or a surface that has holes in it, and when you dry it, the fluid will come out of it, the refractive index will change, and it appears as white demineralization lines or areas. So example, this tooth, wet, you don't see it, dry, you see it. So actually, I have been since about 1995, I examine with a mirror and an air syringe. And then I pick up the Prof to clean the tooth from plaque. I don't use sticking. I used to stick the tooth. My explorers bend. That's how much pressure I put on them. But I found that I'm a better examiner doing it that way. And now I started to think, is this really caries or is not caries? Yes, it is caries. This is at the confines, at the entrance of the pit and fissure. And then there is all this wide demineralization. So this is the beginning of caries. At this stage, we do not want to open the tooth and drill a class 1, because then that will be problematic. A lot of destruction. Remember that the goal of caries management is to preserve the tooth structure. This could be reversed, sometimes could be sealed if necessary. So this is, I just want to review to you some of our concepts. And maybe I'll take this time to explain to you. You all know G.V. Black, is that right? We learned it in dental schools. So G.V. Black did not ever go to a dental school, not like all of you. G.V. Black was a very good carver. And as a good carver, hunter, he volunteered during the Civil War to serve in the army. So he's a ranger. The rangers go before the units to explore things, and he was injured. So he ended up in the hospital, and he worked with surgeons to help them. And he learned two things from surgeons. One, he learned surgical techniques to suture and so on. He also learned that the American surgeons at the time during the Civil War were learning a lot of information of latest technology from Germany. And that's written either in German or Latin, the journals. So when he went and left the army, he decided that he wants to be a dentist because his brother, as a physician, took 2 years. He wants to get married. He needs a faster track. The faster track is to work with the dentist in town, with Springfield, Illinois. He worked for 6 weeks and decided that he could be a better dentist than the dentist he was training with. So he opened his practice. So how did he become famous? So he learned that in order to learn new techniques, because at the time it's mostly extractions, to learn new techniques you need to read German literature. He doesn't read German. But the tailor immigrant, there's a Jewish tailor immigrant down the stairs from his office. He had a deal with him. He will provide him free dental care. He translates the articles for him. So G.V. Black was getting the German literature, reading it, and experimenting with it. And he never did anything that he didn't test it himself. So he developed amalgam. He developed restorative technique. He figured out how to put an amalgam restoration into a cavity and how the cavity will retain that. A lot of his concepts were practical solutions for the time. So this concept that he wrote in his textbook that we use a tiny little tine as an explorer that we stick in the pits and fissure, even though they appear not to be decayed, the probe should be applied with some pressure, and if it enters the enamel a little, so that very slight pull is required to remove it. It should be marked for restoration. Unfortunately, this statement was taken until today, its practice. Until today. So now I bring you to 1910. So after a lot of learning, G.V. Black came up with another concept, which he was very frustrated because people were not listening to him. This is the last lecture, which he says, caries in enamel appears in the teeth of patients. From day to day, these lesions are found in pits and fissures of occlusal surfaces and on proximal and facial tooth surfaces. He started to talk about caries of the enamel, but no one listened to him. So that's why I'm here to remind us that G.V. Black actually talked about this. It's very important. So continue with the foundation. Clinical cavitation then can be prevented. We know that very well. We have succeeded in significant reduction in caries in many parts of the world. If there are optimal conditions that the caries process can be reversed or arrested. And the consensus among many clinicians and cardiologists is that dental caries, like many other human diseases, can be managed conservatively. We don't need extension for prevention. That concept should be gone from the textbooks and not taught at all. Sometimes it may be useful, but majority of the time there's no need for extension for prevention. The fissures could be sealed. If they're deep fissures, could be left and followed over time. So I'll talk to you a little bit about restorative techniques to do that. This is a story of a child whom I met in Detroit about, over 10 years ago. And you can see, you can see the photo better than me. There are 2 demineralization lines demarking 2 caries episodes with this child. The one when the primary centrals and laterals were erupting, which means it's around the age of maybe 18 months, something around that time. What happened when you have the lower incisors caries? That means there's a high caries activity. He ended up in the OR, extracting teeth, and they send him home, and the mother doesn't know much. She's educated, but doesn't know much. She tried to get him to a dentist. Everywhere she calls, they tell her, bring him when he's 3. Well, at 3, he had another episode. You can see when the tooth is fully erupted. But when I saw him when he was 7, these lesions were arrested. So early detection is very important. These teeth are really indicators of a high caries activity. Again, G.V. Black, he recognized from his work and experiments and thinking that in numerous cases, microorganisms causing caries become detached and new colonies do not become attached, which is not biologically correct. In that case, the decay ceases. Afterwards, the decayed areas become dark in color and seems much harder than when fresh. Many such examples are found in extracted teeth. So you have recognized the presence of arrested lesions. So this is not a new concept, over 100 years ago. So if I talk a little bit about the principles that we are teaching now, is that individual caries risk status is very important. We need to, one way or another, to classify patients, children and adults, into caries categories, risk categories from low, medium, high. Some people use extremely high because prevention will be adjusted to the risk, and I will explain that in a few moments. Clinical and home-based preventive and behavioral change plans, including modification and frequency of recall or reviews, should be personalized. So a whole area that we are paying more attention to today is behavioral change models and how we can change behaviors of patients. Again, we're not paid for that now, but it's an important part of total health care. So the caries risk status should guide the development of a restorative plan and replacement of teeth. Non-cavitated lesions can often be arrested and reversed, as I said, using medical or control or secondary preventive management modalities. Restorative care should be designed to optimize the preservation of healthy tooth structure, especially where extension of prepared cavities will not prevent any further development of caries. So I'll show you one example soon, one study. I need to go back. There's a misconception that in high caries patients that we restore all teeth that show any sign of decay because the patient will develop decay anyway. So I started to, and this is just one of many studies. This is a study with Navy recruits, Navy in the United States. They divided them into, when they come to the bases, they divide them, they assess the risk low, medium, high, and you can see the definitions here, which says, and I don't have a microphone. It says, for example, for the high, 4 or more cavitated active caries lesions. Moderate is 1 or 3 cavitated lesions. So it's very arbitrary, but they use some definition to do that. That's fine. I can survive with that. And then, so they classify them. Then they, of course, in the Navy, they will treat all their teeth, and they restore them to send them on a ship for a year or two, or a year of duty. There is dentists on the ship, but they want to finish all bring them to baseline and send them. But what this slide shows that after a period of follow-up, what is the likelihood of repeat restorations? And it was really the high risk versus the high risk kid. The high risk recruit has significantly higher probability of having new restorations. So just restoring teeth is not a solution. This is about survival of teeth in high risk population children, and the same story is repeated, that survival in high-risk population, in high-risk children will be lower than survival in low-risk populations. Now, this says one thing about the biology that I explained in my first lecture. The oral ecology, the microbiome, the diets are consistent. Past caries experience predict future caries experience, which says that we're not changing the ecology of the mouth. As a result, there will be new disease. So that's why the high risk will develop more disease over time compared to other low risk population. This is a survey that looked at, sorry, the arrow here is off, should be up here. This arrow should be here, okay? So you have different levels of caries. Different levels of, this arrow should indicate the early enamel, right here, this lesion. And you go on in these lesions, all the arrows are off. The other one is 1/2 into the enamel. Then you're reaching the DEJ, past the DEJ. They're reaching almost 1/3 of the dentin and 2/3 and more of the dentin. And the question to dentists who answered the survey is will you fill or not? And you can see that for this early lesion, C1, 2% in the low risk, but 9% will restore, and if the child is high risk. And you can see that if the child is high risk, the dentist mentality approach is that we're more likely to fill these lesions because there will be more caries. As I said, the evidence doesn't support that assumption. Restoration of caries in enamel interproximal surfaces, again, depends on the type of practice. This is something to look at. Larger group practices, smaller group practices, public health practices. There are different financial incentive for these practices to push the restoration of teeth, and you end up with totally different percentages. Even like in the low-risk group, 48% for larger group practice and 9% for small practice of 3 dentists. Again, different incentive, different thinking. So going back to what I present to you as outcome, if the outcome is number of sound tooth surfaces maintained as sound, number of active non-cavitated lesions arrested, and number of cavitated or deep dentinal lesions treated appropriately. These are the outcomes that I want to design a dental management program to achieve. And we talked before that in comprehensive care, it's really the issue of diagnosis, a very important step, which means we collect both clinical and non-clinical information from the patient to come up to and risk assess. And then we come up with a diagnosis of sound, non-cavitated and cavitated, low, medium, high, or sometimes extreme high in risk status, and comprehensive plan of prevention, control, restore, and evaluate. I'm starting a different language or different terminology to start to think differently, that in the diagnosis we have a lesion to prevent, which is not a lesion, a service to prevent, which is usually sound. Medical care is to control early lesions from progression, and surgical care, because we're cutting tissue, is for restorative dentistry. So in order to do that, the procedure is, if we look, I'm going to go step by step, though this looks like it's a dental school lecture, but it's important. Staging of the caries is important, so we look at cavitation and activity. And then we must have at least the standard of care, though it is not perfect, radiographic exam. Some dentists may use fiber optic light. There are different tools available. Still, there's a lot of debates and a lot of studies. The radiograph is considered the standard of care today, but may not be in the near future as new technology will appear, and maybe far better technologies than radiograph. So these are the tools that we use today. We talked about the use of explorers. Sharp explorers is actually not necessary. It creates false positive diagnoses, and some of these stained pit and fissures, we do not want to penetrate them and create a hole in them. Rather, we want to keep them as they are and seal them, especially in pits and fissure. My opinion is God created enamel and dentin, and we cannot recreate what God has created. So we need to save it. We don't recommend the stickiness approach to diagnosis of caries. We're using very detailed visual exam of clean and dry teeth. Clean is as much as you can. Some people use a toothbrush. Some people, in most populations, like the population I examined in Turkey, I examined populations in Kuwait, a tooth cleaning by a professional will be necessary in order to see the lesions. But the one I examined in other countries, just the perio-probe will do. So it depends on the population how the teeth are clean. Visual exam is you can classify it into sound, non-cavitated, and cavitated. So on this I think I said that, so I don't need to repeat it. This is a lesion here, for example, similar to the lesion I showed before. This is actually from Detroit. A premolar or bicuspid is erupting, and there's white demineralization. This is very early stages of caries, which could be prevented. So that will be marked as non-cavitated. Why this is important? If you look at studies, many pieces of studies, a lot of them show that non-cavitated lesions are good indicators of future. If you have a population of children, age 1 to 3, and you find in the first years of life, you find a lot of non-cavitated lesions, and our job is to prevent them from progressing because they become cavitated. So if we wait for cavitated and classify these as sound, we're not going to start anything. But with these children at the age of 6, 12 months, 13, 18 months, I'll start a preventive program because they're high-risk children, and then prevent them from having what's called here manifest caries or cavitated caries. So that's an important step. This is a study that's published in Caries Research, a study I did in Detroit, which if we look at the services in primary teeth, sound, initial, and moderate, what's the progression over 2 years? So just by sheer number as percentage, a small percentage of the sound progress to cavitation, extensive decay, cavitation, moderate cavitation. These are definitions that's in the paper. But there's a lot of lesions from sound, a lot of lesions from here, from initial, and then moderate to extensive was about 1/3. So from a public health point of view, if I want to control disease in a population, I am going to focus on the sound and initial lesions to prevent them from progressing, because the numbers are larger than the more advanced disease. The numbers, the absolute numbers, the percentages are lower, but the absolute numbers are higher. So sound is our business in public health, and we want to keep them sound. Radiographic examination, as I said, is considered the standard, at least in where I work, and we classify, we have to take radiographs, it depends. There is FDA guidelines and ADA guidelines when we take radiographs. And the outer half of enamel, definitely we do not restore that. We have some controversy with our board examination criteria, which has actually based on vague, very limited and no evidence, I'll say, that they recommend the students to restore teeth when this lesion radiolucency reach halfway through enamel. Digitally, all of these are digital radiographs, which means that they're going to restore a lot of teeth that shouldn't be restored. And it raises a number of ethical issues and concerns. The board exams are different from the schools. They set them up differently. So we talk to them, but they're not listening so far. When we reach the inner half of enamel, again, this is a low probability of progression, so I use very conservative approach in order to prevent these lesions from progressing and follow them over time. Fluoride, sealants, it depends on the lesion. Oral hygiene practice is what we have today, but there are new technologies that are being tested. The arginine toothpaste here that I think Colgate presented you could be a useful tool to help with these lesions. So we recommend classification based upon extended enamel into E1, E2, and lesion in the outer 1/3 of dentin, lesion in the middle third of dentin, and lesion inner third of dentin. Now, the reason why this is green and red, if it was in Denmark, the green D1 will be green. In other words, in Denmark, at least the faculty I work with, do not agree that we should restore lesions in the outer 1/3 of dentin. The factor that to look at is cavitation. If there's ever a cavitation wherever the lesion, we have to be careful, because once there's a cavity, that's an entrance point for bacteria, and that could cause a problem. And these are the different stages that we're classifying lesions on, from outer 1/3, inner 1/3, and then DJ, middle 1/3, and in the middle 1/3 and the inner 1/3 of dentin. So these are types, sorry about that. These are types of lesions, the outer half of enamel. We have both here a D1 and a D2. This is in the dentin outer 1/3, and the other one is more reaching the inner 1/3. And this is still maybe these definitely are reaching deeper into this is closer to the pulp, although it's a 2D, I cannot say that, but these lesions are deep. Once we have that classification, we can then make a decision by combining clinical and radiographic. This is where opacities in the occlusal surface, this is a deeper lesion, which shows very clearly, I can see it on the radiograph now. Right here. this lesion. Okay? So this is a deeper lesion than what it appears clinically. And when we put these together, then clinically there are three types of lesion: prevent, control, and restore. And radiographically, we have sound, enamel, and dentin. And you can use the word extensive as cavitated, or to be restored either because of dental extension or presence of cavitation. Then we have the lesions that are in the initial stage, and we have sound lesions. Lesion activity is very important. Unfortunately, I cannot recommend to you any tool today, and that's something for the researchers here and the faculty to look into. It's an interesting area. We rely a lot on clinical appearance, age of lesion, color, surface luster, surface texture, plaque stagnation. This is the lesion area where plaque accumulates. And gingival status, it means that the plaque has been there for a long period of time and there's inflammation. Soft walls and floors in cavities. And this is an example. For example, I showed you this before. This is dark, has been there for a long period of time in an adult. So this lesion is definitely more likely, I don't say definitely, to be arrested. The best evidence really is to do serial follow-up of lesions over time and take radiographs to see whether the lesion is progressing or not. Now, the table for that is that we look at plaque stagnation area, which is the pits and fissures on the neck of teeth underneath the contact point. If there is a lesion, it will be suspicious. White, yellowish, opaque, and loss of luster. The lesion is matted because it's pitted on the surface. When it's pitted on the surface, it doesn't appear glossy. Enamel surface feels rough if you have an explorer and you have the tactile capability to detect the surface at that level, which is difficult. Covered by thick plaque, and for cavities, it will be cavity feels soft or leathery. So these are all indicators of activities. So we end up now with a combination of three components: clinical, radiographic, and activity. And the table then will be modified for active lesions, because that's what we want to treat. We can do a table for arrested lesions, similar decisions, based upon whether the cavity is large enough to be a plaque stagnation and bacteria and food and so on, or just to leave it. And then based upon that, the decision is made to restore or not to restore. Root caries is the same story. There is a stage of demineralization which we will call, let me go just to the next slide, I think is better. So you see this is a decision tree, and it's decision tree. First, the decision whether there's an exposed root surface. If there's an exposed root surface, then yes or no. If there's no, there is no caries. And if there is an exposed root surface, we dry it for 5 seconds and look at the surface. Of course, remove plaque and see whether there's any demineralization, discoloration, yes and no. No means no caries. If it's yes, then the next question, is there cavitation? And that in the root will be a form of a concavity. And then we do yes or no for cavitation. And then we look at the surface characteristics. If it's soft, shiny, hard, it's arrested. And if it's rough and matted, soft or leathery. And leathery really for root is just gelatin. You put the perioprobe and you can dent into it, or you can move a little bit of it. It's like glue. That is leathery surface, which means totally demineralized, or not totally, but heavily demineralized. So these are lesions of clinically non-cavitated stages, and these are lesions of arrested, and the other one here is more active and filled with plaque. Root caries is the major problem, as we expect in the future, because of the elderly population that's growing, and we have a lot of people with teeth. So we have three management strategies: prevention, as I explained to you, medical care, and surgical care. What do we do now with those? Non-cavitated caries lesions can often be arrested. We've said that before. These are lesions for medical or surgical. Ask a question. I'll answer it. It could be both. It depends. Depends on the radiographic extension. This is a lesion, again, the neck on the teeth, non-cavitated, but there's a cavity. There's a small cavity because of the thickness of dentin. It's most likely it's there in dentin, but very minor cavity prep and not to extend it all the way and use preventive fluoride varnish and apply it on the surface. It's better to preserve it. For surgical, preservation of tooth structure means we restrict the cavity to the size of the cavity of the demineralized area, and try to, as much as possible, use sealants or minimal cavity preps. This case here is medical care is a combination of two. There's cavitation as well as there's demineralization, so early lesions, and there's cavitation here. So there's a cavitation here, an early lesion. This child is a high-risk child, so I'll fluoride for all the non-cavitated and filling the cavitated ones. I talked a lot about caries risk management, and just to simplify it for you, this is really, we did a literature review and we ended up with all these factors. All the red circles indicate immediate classification as high risk. If the patient had neck cancer, active caries lesions, dry mouth, any pus, fistula, and abscess in the mouth are all indicators of high risk. And then there are other factors, current medication used to cause hyposalivation or hygiene level, topical fluoride use, sugary drinks use, dental attendance, do they have a preventive care on regular basis, family issues that will emerge, care that's provided at home, mother's caries experience. If the mother has high caries experience, then we have to look at the child. Appliances, ortho appliances cause demineralization around them because they trap. Exposed root surfaces. Root surfaces are always at risk when they're exposed to caries, thick plaque, and caries experience, previous caries experience. There are many forms available online that you could use them. This is the ADA forms and checklist of the factors. I don't recommend anyone, I mean, there's no one preferred. They all do the job and could be used. Actually, this area of risk assessment will change as more biology will be introduced into the process as we have better tests and tools. So as we classify them into three categories, then we start to discuss the management. For low-risk patients, the recommendation is oral hygiene review, which I'll explain in 1 second, using disclosing solution after toothbrushing, identify the areas that are missed by the child or by the patient. We use different motivational or behavioral change technique, whatever model you use, improve dietary and oral hygiene practices. Importance of fluoride in drinking water, which I assume that you're going to have it back here. Brushing a fluoridated toothpaste at least twice a day, once a day, twice a day, especially before bed, and for certain kids after eating breakfast or sugary food, or snacks or drinks. Place sealants on permanent teeth and recall every 6 months. That's the recommendation we're following based upon a lot of collection of information from different sources. When I talk about oral hygiene, I'm talking about something more than just telling people to brush their teeth. And this technique is developed and actually tested for over 20 years at Nexo in Denmark. It's called the Nexo method. It's an island of Bornholm. It's one of the lowest socioeconomic areas in Denmark. And they started a dental health program. They had 25 dentists at one point in time, that every child in school will come to the clinic to receive care. Then they changed the plan. What they did, they started very early to call the children, they timed it with the eruption of teeth, started from 6-8 months, and the child will come with the parents to teach them how to do. So engagement of the parents become very important. They focus on oral hygiene extensively, teach the parents how to brush teeth of the children. The parents has to be, I think, with the child until the age of 6. They try to early detect non-cavitated lesions to prevent them from progressing, do fluoride applications, and they don't use a lot of sealants, but they use sealants when they need them. And I don't want to spend time on the models they use. It's a frames model of feedback, responsibility, of changes to have the parents responsible. Advice giving, providing a menu of change options for people to choose from and how they could meet the criteria for improving oral hygiene. They try to be friendly, empathetic, and counseling style than accusatory, and enhance self-efficacy. And I'm going to skip to this photograph, which is revealing. This is the waiting clinic, the waiting room of the clinic. And these are not only for basins, for brushing teeth. There's more. So the children will come from the school, they will brush their teeth. They finish the brush, they go to the dental hygiene chair, the hygienist will disclose them, and the hygienist will map out all the areas they have missed. So once they identify the areas that have been missed, then that will be the prescription for the next visit. And this is what happens. They see this closing, and they could see where the plaque has been left, and they write a prescription, and that will be in the chart to follow up. So now they're providing feedback for the caregiver. And the evidence for that, it's published, is that Bornholm, Nexo, has the lowest caries severity, DMFT, in Denmark. Lowest of all Denmark. But it requires a lot of different intensive management to bring all these children over time. So if we move to the high risk, the moderate risk, again, we control caries by restoring all cavities because you don't want to put foci of infection. 2 minutes after meals is important for brushing, after sugary drinks. We apply sealants on molars, and some people even recommend premolars. Consider applying silver diamond fluoride, though you don't have it maybe in Israel, but it really stains the cavity, but it has the record on it as an arresting agent is significant. It's widely used now. It is on if you have a child with 5 cavities, you cannot restore them. Put silver diamond fluoride, restore the first, and actually people are putting glass ionomer over silver diamond fluoride, most like a temporary restoration. But it will stay and protect the tooth from progressing. Again, the same thing about changing the risk factors, reviewing performance of the oral hygiene over time. The recall frequency is about every 3 months, 3-4 months, again, applying the fluoride again. This is silver diamond fluoride. It has an antibacterial effect because it was just approved about 2 years ago in the United States. It was in the UK for a longer period of time. It has antimicrobial agent, the silver compound. It's part of the filling, part of the varnish, and it's easily applied with a lot of technology. And it has been found to be highly effective. There's actually a Cochrane systematic review, I think, on it, showing that it works. When we go to the high risk group, the same thing we do, I thought we do it more, 4 times a year for fluoride varnish, silver diamond fluoride on cavities, and recall every 3 months. The management of non-cavitated caries, the control part, we have, again, managing the risk factors, sealing teeth, and recall, and oral hygiene. All of these lesions that you see here have been recommended by the American Dental Association for sealants. So non-cavitated caries sealant is not a new phenomenon too. It has been recommended for a long period of time, yet very few dentists apply it this way. But for public health program, going to school and screening and examining children, applying these tools may prevent a lot of problems and actually maybe reduce cost for the program itself over time. So all of these stained pits and fissures in or non-cavitated lesions in children could be restored, could be sealed. Again, if we have restorative, I just want to say that we have moved in the United States. Now the boards do accept what's referred to as slot preparation to conserve or preserve the occlusal surface. We don't need to do the traditional, when they do amalgam, they don't do the traditional GV black outline form. So we abandoned by and large. We use bonded resin restorations, more conservative, less tooth removal, and preformed crowns. So this is a work from Mark Wolf in NYU, and it shows the brown spots are where a caries lesion is. The traditional way is to restore it in a GV black format, which we teach the students in first or second year in operative dentistry. But the more conservative approach will be in C, where the lesions are removed and the rest of the fissures are sealed. And this is a slot preparation with just working with the box than doing everything. The minimal restorative technique is, I'm sure you have heard of ART, and we talked about silver diamond fluoride with GIC, glass ionomer cement restoration, and the whole technique. I'm going to spend a few seconds because I ran out of time. The traditional technique of doing a stainless steel crown take more work. You have to create a space for a stainless steel crown, and you remove caries, and you put the stainless steel crown with the glass ionomer cement or another cement. The whole technique doesn't require that, which has been used and researched in Scotland mostly in clinical trials. Basically, you choose the right size preformed crown, try to adjust the length a little bit, and you put the glass ionomer cement and you put it over caries. It sounds crude, but they investigated Dr. Hall, who did it, about 5,000 crowns, and they found that the crowns have survived, the children have no problems, and there's no progression with caries. And this is, unfortunately, I can't read my slide very well here because it's very bright. But you can see from this slide, if I can read it, pain and discomfort of the children were significantly lower with the whole technique. No anesthesia, it's fast, it looks crude, but the outcomes were significant. These are clinical trials results. There is some evidence when we combine all what I have talked about, that reduction of caries after 7 years was about 33%. Now, this is the only study that exists of this complex system from Australia. 1/3 reduction in caries in DMFT over time when you use a risk-based management, prevention, control of disease, using sealants and fluorides. So the conclusion of my two presentations is that caries is a multifactorial, complex, chronic, and highly prevalent disease. Hence, we need an integrated, comprehensive management protocol that will include staging, risk-based assessment, and prevention. We need to coordinate the treatment plan to prevent and control caries, and minimal restorative care and measurement and assessment of outcome focused on health. Outcomes of care are to prevent the new lesions, control non-cavitated lesions, change risk factors, and preserve tooth structure. And dental public health is the science and art that aims to do these, to achieve this outcome for patients as well as for populations. And thank you very much. Salam and shalom. Okay, good.
Okay. I will thank Professor Aמיד for his two lectures. I believe in preventive, and I think that we as a dentist should believe in that. And after that, after we believe, we should do it with our patient. If anyone needs to ask,
any questions?
Any questions? Yeah.
Firstly, you mentioned the staging view of caries, and you mentioned the difference between different clinics. The staging which you showed us in your clinics in Temple University, do you treat high-risk and low-risk children differently?
You mean in terms of restorative care?
Would you restore treatment at the D1?
No, we don't. No, the same restorative cutoff points for both.
And you do not restore at the D1 level?
No, D1, no, we restore the D1 level. That's the standard that we follow, unfortunately or fortunately. But cavitation is really more, as very important with the D1 level. The United States, by and large, faculty opt to, once it reaches the DJ, passes the DJ, is to restore. So that's a point of contention.
That's at the internet. I see that.
Yes, yeah. Yes, is there a question? You can, I'm very open. I can share with you things. You can send me an email. I can answer your questions. I can share with you a document that describes the whole system. But you can ask the Israeli Arab Association, I can send it to them and they could distribute them to you. Thank you very much.